We have had... Okay. Good evening, everyone. Second time of asking. Yes, call the meeting to order. We have had some delays, but it's more important to start the meeting than to have everyone present. So hopefully someone will join us as we're halfway through the presentation. So as they come in, I'll get them to introduce themselves. Speaking of introductions, my name's Andy Wright. I will be the independent chair for this meeting. My role is to ensure that everybody has the opportunity to have their voice heard, and also to ensure that the panel, who I'll get to introduce themselves shortly, answer your questions as fully as they can. I think a couple of things very, very important to stress. I don't live in Cumbria, I don't work in Cumbria, and I don't work for the NHS. So I'm totally independent. I actually work for the Consultation Institute, and that's why we're here today, to make sure this consultation runs properly. We're here today to talk about the future of healthcare in West, North and East Cheshire. Cumbria? Cheshire? Oh dear. There's one every time, isn't there? Yeah. That's where I was working last, I apologise. Future of healthcare in West, North and East Cumbria. And interestingly enough, I'll mention this now, this whole event's being audio recorded, so everything that we say will be part of the public record, including my Freudian slip at that point. So when we come around to questions, it's really important that you wait until the microphone comes to you, and our colleagues here from South Smith will get the microphone to you. If you indicate to me by raising your hand that you want to, I'll direct questions to you. But when you do speak, it's important that you make sure that you've got good mic technique and you keep the mic close to your mouth so we can hear what's being said. And that's really important because, as I said before, this is part of the public record. So if we don't hear what you're saying, it might be the most important question or the most important comment that's made tonight. If it's not recorded, it doesn't get into the record. So please wait. I'll make sure that everybody gets the chance and the opportunity to ask their questions. And I'll be scanning the room to ensure that everything does happen so. Domestics, there is no fire alarm planned for today. So if we hear it, it's the real thing. And we'll just leave through the clearly marked fire exits out there, and we'll congregate in the car park to make sure everybody's out safely. There are toilets through those doors if you feel the desire. We have a colleague here who's going to be signing. I'm going to ask her now to see if there's anybody that requires translation services. No. Okay. What I'm going to ask my colleague to do is to stand by the door for the remainder of the session, just to make sure that anyone that comes in that requires sign translation will have the opportunity for that to be provided. But rather than wearing out a valuable translator, I'm going to stand you down for the moment. Okay. In terms of accessibility, there is a hearing loop for those who need assistance with their hearing aids, but it only runs round this part of the seated chairs, not at the back. So I asked you at the back if you're all comfortable. Are you all comfortable still? Yes. Yeah, great, thank you. Just checking my notes to make sure I haven't missed anything else important. So it's really important today that we treat each other with respect. That's my job today, to make sure that you do that everything is treated in that manner. So I'll ask you to ask I'm sure you're going to do this anyway, but I'm going to ask you to ask your questions politely to the panel. And at which note, I'm going to hand you the panel over to the panel, rather, to introduce themselves. So they'll tell you who they are and their role. Following that, we're going to have a presentation, and then I'll come back and we'll start the questions and answer sessions. Okay, thank you.
Hello, can everybody hear me? My name is Mark Newton, and I've kept my coat on because it has a badge on it. It's a bit of a clue. I am head of service for North West Ambulance Service, and I'm a consultant clinician as well, so I wear two hats this evening. I've been MWAS's representative on the Success Regime Board for about 12 months now, and I can answer any questions that you have relating to paramedic emergency services or ambulance service related issues. So thank you and good evening.
Hi, can you hear me? I checked my microphone technique. My name's Claire Malloy. I'm Chief Executive at Cumbria Partnership NHS Foundation Trust, which is the organisation that runs the 8 community hospitals in Cumbria and community services and mental health services.
Good evening, everybody. My name's Peter Rooney, and I'm the Chief Operating Officer for NHS Cumbria Clinical Commissioning Group.
Sorry.
To keep going now?
Yeah. Sorry, Peter, if you'd run the presentation, please.
Yeah, so first thing I'm going to do is step off this impromptu stage, because we were quite relieved to have Mark with us, because we thought we were going to have an accident earlier on and kind of fall off the stage and hurt ourselves or something. So it's fallen on me to give the presentation this evening. I'm going to talk to you about the proposals that we have for how we can deliver the very best possible health and care services in the northern part of Cumbria. So we keep talking about West, North and East Cumbria. Just to clarify that means the Copeland area, the Allerdale area, the Eden area, and indeed the broader Carlisle City Council area where we are tonight. So I'll go through the presentation. At the end of that, there'll be lots of opportunity for all of you to ask the questions that you may have. We will endeavour to answer all of those questions. As the chair has already explained, this is recorded through the microphone. If there are any questions that we cannot answer tonight, and there's been quite a lot of public meetings all around the area, and sometimes people do ask things that we simply do not know the answer to. So when we get to that, if we can't answer the questions, we will take a record of it and we will provide the answer as early as we can later and make that available to everybody. I think this is just a test of my ability to multitask, to kind of hold a microphone and press a button at the same time, but thankfully that does work. So, in terms of the public consultation, it runs until December the 19th. There is an opportunity for everybody who lives in our area to take part in the consultation, so we will be using all of the information from the questions and answers that get given at these public meetings, but also an opportunity for people to either answer the questionnaire or indeed to write to us raising any issues that you may be concerned about or that you'd like to be taken into account. And I would urge everybody to do that. So we all live here or use services here. It's your NHS too, and if you have ideas, if you have suggestions, if you have questions, we would very much like to hear from you. So my organisation, NHS Cumbria Clinical Commissioning Group, has the statutory or the legal responsibility to conduct a public consultation on behalf of the whole of the local NHS when we are proposing to make significant changes to services, which is what we're in the midst of right now. So that responsibility rests formally with my organisation, but we will seek to make our decisions in partnership with all of the local NHS organisations and indeed with the benefit of support and expert advice from particularly clinical experts who practice in other parts of the country. The final bullet point there, people keep saying to me that, that this isn't a democratic exercise. Well, it is. If a democratic exercise is about a good exchange of views and people sharing those views and listening to people, that is exactly what we are doing. However, it is incumbent on me to say that a consultation does not amount to a veto. So no one has a right of veto to say you cannot proceed with these changes, but we will listen to everybody as fully as we possibly can. There will be things that we will take into account as well as the feedback that we receive from the consultation. So we have to be mindful of, can we safely deliver services in this part of the world? Can we do that in a way that can be sustained across the medium and the long term? And finance is an issue, and I'll talk a little bit more about that. So the proposals we are consulting on are not financially driven. but we do need to save money in the longer term in NHS services in our part of the world. So, something else that people say to me a lot is, you have already decided what you are going to do. Well, you can believe me or not, this is a choice, perhaps the first choice you can make this evening. I can give you my absolute assurance, we have made no decisions. What we did in advance of the consultation was come to a conclusion as a set of NHS partners, and we discussed this long and hard, all of the areas that are in the consultation document. We had long discussions about. And we came to a view about what we thought was our preferred option at the start of consultation. And that was so that we could be honest and upfront and transparent with you all to say that at this point in time, we think that these options are the best thing to do. That is not the same as saying we have decided what the outcome of the consultation will be. And as I said earlier, we encourage you all to take part in the consultation, and thank you for coming this evening. It's a great sign of your interest in our local NHS services. We have not made any decisions. The next thing to flag up, all of the responses from the consultation, including the question and answer session tonight and so on, will be collated and analysed by an independent organisation. They will produce a report for the local NHS that will account for all of the issues that have been raised around the areas that we're consulting on, and they will produce a document. And the document will be very helpful for us in coming to our final conclusions, which will be around about the early springtime. My understanding is that we will make the document publicly available. So you will all have access to see the range of feedback that was given during the consultation. So, lots of you already know this, but we do face some big challenges in our part of the world. The first line says our population health is not good, which is a little bit misleading actually. So there are parts of North Cumbria where population health is good relative to the rest of England. So if you just use as a measure of that, just how long people live, there are parts of our area where people do live significantly longer than on average in the rest of England. But there are parts of North Cumbria, and there's links here to wider issues like social inequality, like wealth inequality, like housing, employment, and so on, where our population health is significantly worse than other parts of England. And altogether, as an average, it is slightly worse than the average would suggest. The second bullet point is a massive issue for us. It is perhaps the biggest driver why we are having this consultation, which is, although, and I know this, this is a wonderful place to live, it's a wonderful place to work, it's where I choose to live and work, but we have massive issues in our part of the world in attracting and retaining the right workforce that we need for the future. So some of you who are from the immediate vicinity of Brampton will know that there've been some real issues about attracting nurses to come and work in the Brampton Community Hospital. There are real issues across all of North Cumbria around attracting general practitioners to work here. Our vacancy rate in general practitioners is significantly worse than the national vacancy rate. And at both Cumberland Infirmary Carlisle and indeed at West Cumberland Hospital, we have really struggled over a long time to attract doctors, surgeons, nurses, occupational therapists, physios, the whole range of health and care services to come and work in our area. It's a real challenge for us. This is increasingly a challenge across the rest of England. It is more acute here. Overall, again, compared to national averages, there are a higher rate of hospital admissions in North Cumbria, and particularly how long people spend in hospital once they are admitted is longer than it should be. And of course, we should all be grateful to have hospital services. When we need them, they are what we need, but it's not in anybody's interest to stay in a hospital either at Cumbria Infirmary Carlisle, or indeed in one of our community hospitals, or indeed in one of our mental health inpatient units. It's not in your best interest to stay there longer than you need to. I said that I'd mention money. I think there's another slide later on. But our local NHS system is spending far more than it is allocated by central government. Our local NHS system every year is running at a loss, and essentially we are spending money which is meant to be available for other parts of the country. Final point here, the Care Quality Commission, being the regulator for NHS services and indeed many social care services, deemed some services, a small number of services, to be inadequate, which particularly related to some of the services in the North Cumbria Acute Trust and also a specific service in the Partnership Trust. So, for quite a while there's been uncertainty around what is the direction of travel, what is the solution to these problems, and uncertainty really doesn't help. So if you've got a problem recruiting staff, and those staff know that you may make a big change to that service that you want them to come and work in, they're probably not going to come here. So uncertainty has really not helped with the recruitment. It doesn't help all of us as service users and patients in knowing what the care will be in the future, and we need to come to some conclusion. There's a risk whenever we give these kind of presentations, it all sounds a little bit doom and gloom. So apologies for that. So to get on the front foot, a key message we really want to get across to everybody is that we don't aspire just to fix some of these problems, though that would be a great start. We aspire to deliver the very best health and care services that can be delivered in a place like ours. We want to be recognised nationally and internationally as a centre for excellence in terms of providing integrated health and social care provision in rural, remote and dispersed communities. That's quite a mouthful. And I know for those of you who've come across from Carlisle tonight, there will be some. Carlisle doesn't really feel like a rural, remote and isolated place, but it is in terms of the geographical distance to anywhere else. And even more so for those of you who come from Brampton, Longtown, the surrounding areas. So, we're not consulting on this, but it's an important piece of contextual information. We want to bring together how health and care services are delivered in our communities by general practitioners, by social workers, by community nursing, by physios, by therapists, in what we termed integrated care communities, so that those frontline practitioners that deliver the vast majority of care and that we all rely upon work together in a different way and in a much more joined up way than they ever have done in the past. With an absolute intent that we will deliver care as close to home as possible and as appropriate. And there's a lot of history of kind of joint working between different organisations in the health and care system, but we recognise that every day, although some of our services are fantastic, every day we don't quite get some stuff right that helps somebody to get the care and the treatment that they need as quickly as they need it, in the right place that they need it. And we think we can make a big difference by getting people to work together in this way. These are some of the other kind of objectives that we have. So I guess from my perspective, we have an absolute responsibility to be as confident as we possibly can be that the care that is delivered is clinically safe. Now, inevitably, medicine can be a messy business, and probably everyone in the room will have had some experience, either themselves or for their families, when things have gone wrong. And healthcare can go wrong, but we want to make it as safe as it possibly can be against 21st century standards. Quality includes clinical safety. It also includes patient experience, so we want people to have the best possible experience of using our services that they can, and we want people to get the best outcome from those services. So that's kind of what the quality point's about. And the last 2 points are, it's got to be deliverable in the longer term. So clinically sustainable means that it will deliver contemporary standards, that we'll be able to have the workforce in place to deliver it. And financial sustainability is simple. It just means that it can be afforded in the longer term. And that is a real challenge. So, in terms of the areas that we're consulting upon, so there's lots of changes that we will seek to make in terms of improving healthcare all of the time, everywhere it's delivered, forever, but there are some specific things that we're seeking public views on. The first is this. Throughout all the slides, the preferred option in the consultation document is shown in, I'm not sure what colour that is. Is it purple, blue? The one that's not black anyway, that colour. So for children's services, we're really talking about inpatient children's provision. There are currently an inpatient paediatric ward at the West Cumberland Hospital over in Whitehaven and in the Cumberland Infirmary Carlisle. Our preferred option would lead to us having what's called a short-stay paediatric assessment unit at West Cumberland Hospital. The vast majority of children that present in hospital, either through a GP referral or through A&E, can receive the care that they need there and then and go home after a fairly brief intervention. And that's partly a change in the nature of childhood illness. It's partly a change due to the massive success of the immunisation programmes that we have. Most children can go home. For those that can't, there will be overnight what's termed low acuity beds at West Cumberland Hospital. Low acuity just means for children who are not deeply ill, don't need a huge amount of complex intervention, but do need monitoring and stabilising and keeping in. And at Cumberland Infirmary Carlisle, same thing, short-stay paediatric assessment unit and a fuller inpatient service. The second option that we looked at was that Cumberland Infirmary Carlisle keep its provision, and at West Cumberland Hospital there would only be the short-stay paediatric assessment unit with no overnight beds. So that's the key difference there. And the third option is a fuller consolidation of the inpatient children's service to Cumberland Infirmary Carlisle, and at West Cumberland Hospital, effectively there'd only be a day service and outpatient service. So those are the options that we're consulting upon there. In terms of maternity services, I think it's probably worth saying that the antenatal and postnatal services will continue at both West Cumberland Hospital and at Cumberland Infirmary Carlisle. So there'll be a full range of outpatients, full range of diagnostic services and so on. But what we're really consulting on here is where women have the opportunity to give birth. So in the first option, we would continue with a consultant-led unit at both West Cumberland Hospital and at Cumberland Infirmary Carlisle. In the second option, there would only be a consultant-led service in Carlisle. And at West Cumberland, there would be a midwifery-led service. And to give you an idea of the change, there are currently something like 1,300 births a year at West Cumberland Hospital. If we went ahead with this change, then there would be something like 300 to 500 births at West Cumberland Hospital, depending on the choices that women make. And in the third option, all of the births would take place at Cumberland Infirmary Carlisle. There would not be that same opportunity at West Cumberland Hospital. Just one thing to clarify. Of course, we are in the business as far as possible of giving women as many choices as possible, including promoting home birth, where that's an appropriate and a safe thing to do, and where that is a choice that the woman makes. And also, in all of these options, we will retain the birthing unit down at Penrith Community Hospital. So that one won't be changing. Community hospitals. So across all of the community hospitals serving North Cumbria at the moment, we intend to sustain all of them. So community hospitals will not close. In fact, we can see a vibrant future for all of them, particularly as a base to deliver some of the integrated care communities, a greater opportunity to deliver outpatient services, and a greater opportunity actually to deliver a broader range of services in our community hospitals. What we're consulting upon are the places that will continue to have inpatient beds. at the community hospital. That's the first distinction I want to draw. It's really difficult to describe these options without endlessly repeating yourself, but our preferred one is that we would reduce the number of community hospitals that keep inpatient beds to 6, which would result in the beds not being retained at Alston, Wigton and Maryport. Under option 2, same proposal, plus either Cockermouth or Workington would no longer keep the community beds. And option 3 is a reverse around Cockermouth and Workington. The last option would result in us only having 3 places with community beds, which would be the Penrith Hospital, somewhere on the West Cumberland site being an expansion of the Copeland unit, and a new unit to be determined somewhere in Carlisle. As I said, the preferred option is the one in blue. Emergency care. So we think it's really important, if we possibly can, and it really is a if we possibly can issue, to retain a full accident emergency service at both West Cumberland Hospital and Cumberland Infirmary Carlisle. In order to deliver that option, we will have to find new workforce solutions with staff working in a very different way, with an extensive training and professional development programme for staff, and maximising all of the skills, including from the nursing workforce. We think that that can be done. We think it's a really exciting option, but it's going to take an awful lot of work, and it will have its challenges. The second option would essentially be that at the West Cumberland Hospital, there would be 24/7 an urgent care centre, meaning it can deal with minor injuries, minor illnesses, and those kind of presentations, but the full A&E service would only be available during the daytime, which would mean that at some point in the late evening, the full A&E service would close, and anybody who required that full A&E service would need to come to Cumberland Infirmary Carlisle. Yeah, and the last option, sorry, I was worried I'd confused myself at that point. The last option is essentially that none of that A&E provision would still be at West Cumberland Hospital, but they would still be the urgent care centre, as I said, dealing with more minor injury, more minor illness, that would be retained 24/7. We're nearly there. So, hyperacute stroke services. In lots of places across England, they have centralised stroke services in terms of the really acute phase following a stroke, where the first 72 hours particularly are incredibly important in terms of saving lives and in terms of helping people to ensure that people have the best chance possible to recover after they have had a stroke. And those first 72 hours particularly, your outcomes are better, you are safer, you stand a better chance of living and having reduced disability if where you receive your care, there is a hyperacute stroke unit with the right physicians, the right nurses, the right speech and language therapists, the whole support services in one place. And we think that we can improve outcomes all across North Cumbria by centralising that resource at Cumberland Infirmary Carlisle. So that is our preferred option. It's worth saying the other option at the moment, we are not able to provide that really hyperacute stroke service at both sites 7 days a week now. So there are plenty of places across country that have much better outcomes than we do, despite the staff on the ground doing a fantastic job in very difficult circumstances. I think that's it in terms of the options. We must be nearly there, but in terms of the financial position, so I did say I'd cover this. In the 2015-16 financial year, the NHS across North Cumbria spent £70 million more in keeping the lights on, paying the staff, making sure prescriptions are available, etc., then we are allocated. So the NHS in our part of the world is significantly overspent. If we do nothing, then we're forecasting that by 2020, that overspend could reach higher than £160 million a year. We do not think it is an option to do nothing. In terms of the areas that we're consulting upon, there is a small financial change and financial benefit if the options that we are preferring at this point in time go forward, which is a bottom figure, which is of the order of 2.1 million. So predominantly, the things we're consulting upon, we want to do because we think that they will improve quality, they will improve safety, they will improve the outcomes for all of us who live here. The really, really big changes are in the local NHS trust becoming much more efficient and saving in excess of £80 million over that next kind of 4.5 year period. And new ways of working is largely savings that we can deliver associated with integrated care communities, particularly reducing how long people need to spend in hospital. So, West Cumberland Hospital, I don't know if any of you have been. It's a wonderful, wonderful place. An investment from the national government in excess of £90 million. There are parts of the hospital now where if you were someone who worked in the NHS, it's a great place to deliver care, and for people who use it, it's a great place to receive care. And we're very, very committed to there being a positive future for the West Cumberland Hospital. Some services that have moved on either a temporary basis or were moved in the past for immediate clinical safety reasons, we would intend to take back to West Cumberland Hospital, particularly some of the areas around minor trauma and some surgery. And that will clearly have a benefit also at Cumberland Infirmary Carlisle, because it will free up some capacity at the local hospital here. I guess the key message that we also want to give around West Cumberland Hospital is that more people will receive a broader range of treatments in that hospital than they ever have done before. So there will be more provision of outpatient care, there will be more provision particularly of elective surgery than there has been in the past. I've gone on long enough. Thank you all for being so patient. I think we'll be moving to questions.
Thank you, Peter. Thanks very much. Thank you for that. As I said, it's now the opportunity to ask questions. Just allow my colleague to join us, and if you wouldn't mind just introducing yourself, Debbie.
Hello, my apologies for my lateness. I'm Debbie Freak. I'm Director of Strategy at the Acute Trust.
Okay, thank you. So we have a gentleman here who wants to ask a quick question. Sorry, before we start, I should just say that if we could keep the questions as concise as possible to allow everyone the opportunity to speak, and I'll also ask the panel to keep their responses as concise as is appropriate. Thank you.
Thank you. My name is John Holland. I'm the chairman of the Friends of Brampton Hospital. As you might expect, what I want to say relates pretty well specifically to the community hospitals in general. And whilst it isn't a question in a sense, it may well answer a lot of questions and save some time for the rest of the evening. So if you will bear with me, you'll see what I mean. The first thing to say is that we have produced a report, and I'd like to hand you a copy, if I may. Most people who are here, quite a lot of you, will have already been here in June. Unfortunately, the success regime weren't. And we, as a result of that meeting, we produced a report which we sent to the success regime. And what we've done since then is to update it in the light of changes. If I could run through those changes and what we propose as the Friends of the Hospital, I think it would be beneficial, Mr. Chairman.
As quickly as possible, please.
It will be. Anybody who wants a copy of this, it is available. I can email it to you. It's on our Facebook page, whatever. There's a lot of point made of the things which we believe are wrong with the consultation technically, but I don't want to dwell on those tonight. What I do want to do is tell you what we are actually doing. The presentation we heard said the principal problem we have is not really money, it is recruitment or the lack thereof. So we took that on board, and what we've done is we've talked to the Trust's HR department in some detail, and we have funded a nurse and other staff recruitment fair, which will happen at the Holston Hotel in Carlisle on the 4th of December. This is being fed from 2 other Royal College of Nursing fairs, which have taken place in Glasgow and Liverpool, and 110 leads were produced from those 2 places. Also, we hope to encourage a great many of the 803 qualified nurses who do not currently work for the NHS, who live in Cumbria, to come and have a look and think, would they like to work in a community hospital? To that end, we are paying for advertising in the local newspapers, and what we hope to get in addition to that is a fair bit of editorial coverage. This is a very practical step. We are offering an element of travel costs to people who travel from away to us, and we are genuinely trying to get those staffing gaps, both the nurses, the occupational therapists, the physiotherapists, and other classes of staff. Let's plug those gaps, and we will work very hard to do that. This is not a promotion merely of Brampton Hospital. This is for all of the community hospitals. We have changed the banner outside Brampton Hospital, as many of you will see, from Save Our Hospital to Recruiting Now, and that is true. That reflects the truth. And that was done in cooperation with the HR department of the Trust, who have been tremendously constructive and helpful. Everything is here for you to read, the bad bits and the good bits. I would make one further brief, important point. The one place that I think is really being badly treated in this whole consultation is Alston. Those of us who live here and know what the travel is like, particularly in the winter months, and let's face it, in Alston, that's basically anything up to April from November, it is a difficult place to get to and from. Those people are going to feel very stranded and very vulnerable. I do not feel happy about that. I don't think the cost of reversing that decision is significant in the greater scheme of things, and I would appeal to you to make that point as forcefully as you can to all of the panel. Thank you.
Thank you, John. Okay, Claire, if you want to make a response.
Yeah, thanks very much for that, John. That's really great. I just wanted to say a couple of things. I suppose we're really grateful to the League of Friends. So both in terms of the proposal that you've done with stakeholders of what role you think the community hospital could play, and some of the ideas that you've got for the services there, because I think I'd reiterate what Peter said, and that is that we do see a really valuable role for the community hospitals. This consultation is not about closing community hospitals. We're committed to retaining all of them, and we want to develop the services there. And we're also extremely grateful to the League of Friends for the work that you've been doing with us in helping with recruitment. And I understand that it's been starting to be pretty successful in Brampton, so really fantastic work. If we can replicate and learn from how you've been working with us here and do that in some of the other places, it would be really good, wouldn't it? So thank you for that. Just to pick up the issue of Alston, you're right, John, it's an isolated community, and we don't feel particularly comfortable at the moment. We're doing some work with that community to see if there is an alternative. As part of the consultation process, we're working with the League of Friends, but also other stakeholders, to see if there is an alternative that we could develop during the consultation period that we can put into the consultation as a viable option. So in Alston there are some nursing care beds, there are residential care beds, there's some sheltered accommodation. What we've been doing, the local community there, facilitated by the League of Friends, have been looking at whether we could develop an integrated facility that brings together the general practice, the beds that are provided by others with our beds into a different type of, potentially a different type of bed, and potentially provided by in a different building. We'd need to put in some capital if we were to do that, but we're currently exploring that, and then we will feed it into the consultation process, because I do acknowledge what you've highlighted. It is a fairly isolated community. I think we're going to have to think a little bit about the proposals there.
Thank you. That raises two important points before I start passing out some other questions. Very important point. Well, John, I'd like to make sure that everybody knows where your Facebook page is before they go, so they can get that report. And also, it's been raised the fact this is not the only way in which you can contribute to the consultation. This document provides all the ways in which you can. So please look at that. If you don't get the opportunity to speak tonight, ensure that you look at the documents at the website, find all the different ways that you can respond. Okay, so I'll take questions again. Yes, lady here.
I support everything that John has said, so I'll just move on. I've got two questions, and they're both two separate areas. One is the midwife-led unit in West Cumberland Hospital. I would like to know how that's going to benefit our expectant mothers. There was a report out a few years ago which said that we have a worse infant mortality rate than most third world countries. It is not appropriate for a midwife-led unit to be that far from consultants. I have personal experience of a child who died because there was no space at the consultant-led hospital for the mother to go to, so she lost one of her twins. The other question is that you talk about having care closer to home. Existingly, there are 133 beds in community hospitals, but they're going to be reduced to 104. How is that going to stop bed blocking in the main hospital? Again, I have experience of a friend who was in Cumberland Infirmary for 6 to 8 weeks. She shouldn't have been in that hospital for that time. She did not need medical care, but there was nowhere else for her to go. She ended up in a ward of other patients who had dementia because she wandered, but that was the nature of her condition, and there was nothing that medically could be done about her condition. She couldn't go home because she fell over. She even fell over coming home in the ambulance. She couldn't keep her balance, but there was nowhere else for her to go. And reducing those beds is going to mean that there are going to be more people like my friend who are going to end up bed blocking.
Okay, thank you very much. Two important questions. Debbie, you're going to take them first?
Yeah, shall I start? I'm sure colleagues may want to come in as well. About the midwifery-led units, first of all, the whole question of maternity is really difficult, and it's been difficult for more than 10 years to my knowledge, and I'm sure that discussions have been going on about maternity longer than that. If there was a clear and simple solution, it would be easy for us all, but there's not. And so we need to try and understand what the options available to us mean in terms of the relative risks and the relative advantages on all sides. And it's not clear-cut. We have stated a preference because we committed to stating a preference, but actually it's really not clear-cut at all, and it's very difficult. We have, through the process of the Royal College Review, looked at all of the evidence that we can find. Some colleagues through consultation have found us even more evidence that wasn't available to us before, and that's been very helpful. But what we know through the process of the review is that there is no single piece of evidence that says this is the thing that you should do. So we need to gather all the evidence that is there and make some sort of balanced judgment about it. We've also determined that it is almost impossible to set any figures on those different options. So when we look at the options of a midwifery-led unit, and we know that midwifery-led units have very good outcomes, we also know that there are times when women need, as you've already illustrated, urgent assistance, and we need to understand what those risks are. We need to balance against that the risks of trying to run a very small consultant-led unit propped up by locums very distanced from the main site, and that's the thing that we're struggling with. So it's not clear-cut, and I would just ask you to understand that we have spent a long process gathering as much evidence as we can, and where there is no research evidence that we can base a clear decision on, asking the opinion of experts. If I can come on to what you were saying about bed blocking, you're absolutely right that changing what happens in community hospital beds per se isn't the answer. We think that integrated care communities, an entirely new way of working, is where we're getting to the answer.
Sorry. The question was, what do you mean by
an integrated care community?
Just for the record.
So I think I possibly missed that bit as I was just coming in, but Peter, I think, outlined integrated care communities probably during the consultation. So the thoughts are that we would organise care to be based around the needs of the individual patient and their family, to join up the services around meeting those patients' needs, to work across health and social care, bringing in expert support when needed, reduce the number of duplications and wasteful care, and stop patients thereby going into hospital beds when they don't need them, and manage to take them out of hospital beds sooner. And not just out of acute hospital beds, but out of community hospital beds too. So we know when we've looked at what happens in all of our beds, that patients are often not in the best place for them. So you gave an example where somebody was not necessarily in the right place for them. We know that there are many patients who are medically fit for discharge who don't need to be there, either in the community hospital beds or in the acute beds. So what we need to do is to find a way of getting them into the right place at the right time, stop them going into hospital when they don't need it, and ensure that they can get back sooner to their place of living and live independently.
Claire, do you want to add something to that, please?
Yeah, I just wanted to make a couple of points, really. You're right, we do have 133 beds across the community hospitals, but we haven't had 133 beds open over the last few years, actually. So during the summer, it got down to about 100 beds, actually. Because of the issues of staffing, we haven't been able to staff all of our beds. So that's one of the challenges. It's also fair to say, as Debbie says, that we know from audits that we've done that very often we have people receiving care in the wrong place, particularly either in a bed in an acute hospital or in one of our community hospitals. And you've absolutely hit the nail on the head when you've said that's because there isn't the right range of alternative services. And so one of the things that we're trying to do is to put some investment into increasing that range of alternative services so that it would support people to be cared for, I suppose, in other types of beds. So mainly people's own homes, but also supporting the community teams that go in to support people in care homes or in residential care homes. But if we don't invest or develop those other services, then we will make the problem worse. We will get more bed blocking. So you're absolutely right on that. But the whole point of the integrated care communities is to try to shift that investment from currently treating people and caring for them in the wrong place to putting it into services that can support them in the best possible place for them.
Okay, thank you, Claire. There's a gentleman here.
Thank you. I'm David Morat. Following on from integrated care communities, we're very impressed, certainly and it's a pity that more details haven't been provided for the local community to explain what integrated care communities can achieve. The slide said it intends to provide safer services that currently exist, services of a higher quality than currently exist, that they're clinically sustainable and financially sustainable, and certainly deliverable in the long term. That's an absolute excellent concept, and we can congratulate the thinking behind that. Because most people do actually prefer to be cared for at home. I would actually put my money on that. However, it all depends about budget alignment. It means that health and social services together have got to provide the funds to make that happen. If you can promise us that an integrated care community can provide the same safe services and high quality that currently exists in community hospitals, I'd go along with you. But let me just remind you, we are told today that Stuart Young, who's the chief officer.
He's the leader of the council.
The leader of the council, thank you. He claims not to have been consulted by the SR. Okay. I also want to remind us that county councils have not got a good record of funding care at home. Just imagine somebody being cared for at home in Road Head, and at 3 o'clock in the morning, they're either got a lot of pain or fall or are ill. Under the integrated community care system, will a service be provided out of hours 24/7? At the moment, there are 1.2 million over 65s nationally who are actually currently going without help. 300,000 of them have daily difficulty in dressing, washing, and going to the toilet. That's basic care, not health, but social services type stuff. Councils nationally have actually suffered severe cuts that you and I know well. And they can now only manage 50% of the demand. So can you see the picture I'm painting? If councils have failed to help more than 75% of the people who have applied to them for help, and Cumbria County Council is one of those. Local experience from social workers and health workers, because I have contacts. I used to manage a community hospital, so I'd like to think I know what I'm talking about. Okay? The existing long delays in getting care at home assessed. They do not currently get an out-of-hours service. And in Brampton and Longtown district alone, at this very moment, there are 32 people waiting for an assessment. 24 who would require overnight care but don't get it. So, to summarize my points, if you can promise us that integrated care in the community will be fully funded, we might be sympathetic to the idea. Okay. Lastly, if it is to be introduced, we'd like to see a transition arrangement whereby that works alongside community hospitals together at the same time until it can be proved that there's adequate funding from Cumbria Social Services to make that happen. Otherwise, we're not going to play.
Okay, thank you.
So firstly, thank you for your question. You raise a really important issue about social care. And unfortunately, there's nobody here on the panel this evening from Cumbria County Council, but I'd like to say a few things, not on their behalf, but as a partner with Cumbria County Council. So actually, Claire and Debbie and I have spent the afternoon with our colleagues, including the Director of Health and Care Services from Cumbria County Council, talking about exactly this kind of issue. There is a huge challenge in providing good social care for everyone who needs it, which is one of the factors why we do have overpressure in both our district general hospitals and in also our community hospitals. There is a real thing to resolve. And we are working very hard with our colleagues in social care to make sure we've got the very best provision that we can have going forward, despite a massive financial challenge. Now, some of the ways that we can address that are that more people in North Cumbria spend longer in residential care than they do in other places. And residential care is very expensive compared to delivering services in the community. And most people who go into residential care would have preferred to have stayed at home for a lot longer. And if we can provide better services that support independent living, that is both cheaper to do and it's better to do for the individual and for their family. The second thing I want to pick up, having mentioned families, of course, the real amount of care provided, particularly for frailer and more vulnerable older people, is from their families and their carers, who don't ever get recognised and certainly don't get paid. And we would always want to pay tribute to the work that they do, because without carers supporting their loved ones, there would be a much greater pressure in the health and care system. So that's a really important thing, that how can we support carers in a better and a fuller way? I don't know, Claire, if you wanted to pick up a couple of the points.
Well, just to emphasise that the County Council are full partners in the development of integrated care communities, so they're very committed to the development of those communities. I think we all recognise that unless there's some investment that's able to be put into strengthening social care, then the integrated care communities are not going to work, actually. So your point is really well made, and that's at the heart of the investment that I was talking about. So what we're trying to do is to look at where we're currently investing money in places that support people where, you know, it's not the best place to support them, and to look at how we can shift that. So we're having a discussion about how we can do that, but we have identified in the strategy that we've all signed up to that there will be significant investment needed to be made in community services, in general practice, in primary care and in social care, in order to effect the changes that we want.
Apologies, just picking up what Claire said, because one of your questions was about, is there potential to run both services at the same time until it proves it works? So over the summer, we worked long and hard of what is called the pre-consultation business case, where we had to demonstrate to the national NHS that we had a good clinical strategy and that it would work financially. Now, part of the pre-consultation business case, and you can read it, it's on the website, includes a financial analysis, which has a £4.1 million investment in 2017-18, that financial year, and in the following financial year, that is part of the transition cost to support double running where it's needed. So there is a financial provision to seek to do what you said, and to demonstrate that we can make these changes safely and in a timely fashion. I guess the last thing to say is that we will not be closing beds. We will not be closing beds unless it is clear that we do have capacity to deliver appropriate, safe services in the community. So, you know, we're very, very mindful that we can't just all of a sudden have a big bang, make lots of changes and hope it works out. We will only do that as we can strengthen the community services and build confidence that we don't need that bed base any longer. Thanks, so.
Debbie, do you want to? Yeah, okay. Thank you. You picked up the point I was going to ask you to respond to. Thank you for some well-made points. I'd like to ask some people at the back. There's some hands up at the back. Yeah, it's been asked. Okay. Anyone else? Any other questions, please? Lady there.
Hello there. I just wrote down 3 things. I've got no axe to grind here at all. First of all, why are we overspending? Is it because we haven't got enough? Don't we ask for enough? You know, why are we overspending? And I actually haven't heard anything that's going to stop us from overspending. That's point number 1. Point number 2 is you say there's a shortage of staff. If we haven't got enough staff for the hospitals, etc. now, how are we going to have enough staff to treat everybody at home? I mean, David mentioned Roadhead. I live in a rural community, and I couldn't get care when I needed it. So that's in their own home. And thirdly, someone mentioned that in the summer you close some community beds. I just wonder if you have any figures concerning how much bed blocking went on at that time. That would be interesting.
Thank you. Thank you. 3 good points. So we'll address the financial first. Why are we overspending?
I'm going to make a start on this. Debbie may want to add. It's a really good question. So I think that as we work through all the issues I said around the pre-consultation business case, about to understand the money we currently spend and to get the best use of it, part of that is to make an argument to central government to say that a place like North Cumbria, spread over 2,000 square miles, 330,000 people or so, very low population density, lots of rural areas, inevitably there are some what would be termed excess costs, so some extra costs of delivering healthcare in a place like ours, and there is a case to be made that we should be allocated more. So I think that is one of the issues that we raised. Central government will only listen to that argument if they can see that we have exhausted every possible local measure to live within our means. So that's what we're being tested on, and that's what we're trying to demonstrate. In terms of the why we currently overspend, and this may be the point that Debbie wanted to pick up. So one big area is that when you do have a shortage in the workforce, you still have to provide safe care and make sure that wards are adequately staffed, that GP surgeries are adequately staffed, and so on. And part of the extra money we're spending now is because paying for locum staff and paying for bank staff is usually much more expensive than having permanent staff. So if we can get to a point where we can have permanent staff, which also gives you better opportunity in terms of continuity of care and those staff really owning the services that they deliver, that will save some money. A second area is that if you do have 2 district general hospitals, where normally for a population of our size, you would only have 1, then inevitably there are some extra costs associated with running 2 sets of rotas, 2 sets of services, and that's part of the issue. And I guess the third thing is that there are lots of efficiency savings that places outside of Cumbria have done to deliver care safely but more cheaply, and we still have lots of opportunities to do those same things. And that's a really big test for us. Debbie, I don't know, did you want to pick up on that?
I think, Peter, you've picked up on most things that I wanted to say. One thing is to come back to something that I think Claire was talking about earlier, which is about reliance on models of care which are very expensive. So waiting for a patient who could have been identified as being at risk and have a care plan put in place and some good preventative actions, waiting for that patient to become ill and end up being transported by a 999 ambulance into an A&E department and then taken into an acute hospital ward and then having a period of rehabilitation is actually a very expensive way of doing things. So part of what we're expecting is that in investing in our integrated care communities, we can remove some of that costly care, and it's not just in the acute sector either, it's obviously in other areas too, including in local authority provision, where actually keeping people long-term in residential or nursing care, rather than having put the investment in the reablement services to help them live independently in the first place, is a bit of a false economy. And the last one, to come back on what Peter was touching on about efficiencies. So we know that we can do an awful lot more, make our pounds better spent by really focusing all of our staff on making what we do more efficient, reducing some of the duplication and waste that we know that there is in the system. And a major part of our work plan, and probably not one that we've mentioned so far this evening, about achieving some of those efficiencies, is about having a comprehensive and consistent, standardized approach to how we're going to tool up all of our staff to make sure that we do things in the most effective and efficient way, so that they feel empowered to make those changes within their services, where they can see the waste for themselves, and so many of our staff often tell us that, and that they have the tools to help them get on and do that. So we have the Cumbria Learning and Improvement Collaborative that has been commissioned through the clinical commissioning group that we're all partners partners of to do that improvement work, and that is going to be a major part of the change in the way that we do things around here.
Okay, thank you. So that we've addressed the question of how we're going to balance the budget.
Just come in before you move on to the other questions. You mentioned locums. Why are they long-term locums? I only ask this is not Cumbria, in Newcastle. The consultant who operated on my husband 3 years ago was a locum neurosurgeon. My husband's seeing him on Wednesday. He is still the locum neurosurgeon, 3 years on.
Okay.
That's not cost-effective.
Okay, thank you. So that I think that reinforces the point rather than asking another question. So if we could move on to the shortage of I think it's a point well made. Move us on quickly to the issue around shortage of staff. If we're short of staff at the moment, how are we going to be able to treat people at home, specifically or especially in rural communities? I don't know who wants to take that first. Okay. Thank you, Claire.
Yeah. Well, it's a fair question, isn't it? If we're struggling to support them in a community hospital bed or in an acute hospital bed, how are we going to provide the wraparound care in the community? I think there's a couple of things in there. I think generally we find it, and this is just my experience from our organisation, and we find it easier to appoint to our community teams than we do to appoint to our community hospitals. So we generally carry less vacancies in terms of our community nursing teams than we do when we're appointing to our community hospitals. I think the other thing is to say that it's about the reliance on a different sort of workforce as well. So in our beds in the hospital, it's predominantly a nursing workforce that provide the care. When you're supporting people in their own homes, you can think about the role that therapists can play. And actually, generally in Cumbria, we don't have so much of an issue in recruiting occupational therapists, and yet they play a massively valuable role in supporting people to recover and return to normal living. So I think what we're thinking about is there a different type of workforce when you are supporting somebody in their own home? Because you wouldn't be supporting somebody with the same set of needs in their own home. For somebody who did need still medical and intensive nursing input, you would still be supporting them in some sort of hospital bed. But what we're hoping to do is to support a lot more people so that they don't get to that level, or that they can be stepped down at a quicker point because we've been able to put in the right level of care in their own homes. And you asked about bed blocking during the summer last year. I can't provide you with the exact details from that period, but I know when we've done audits before and we've looked at people in our community hospitals, and generally it's somewhere between about 20 and 40% of people who, if we were able to provide a different sort of service in their own home, and that includes social care, because sometimes those people are waiting for domiciliary care packages to go into their own homes, and sometimes they're waiting for placements in a care home or a nursing home. But if we were able to provide that range of alternatives, you've got about 20 to 40% of people that wouldn't need to be waiting in a community hospital bed. If, yes, absolutely. And it comes back to the point that I was saying about you've got to be able to invest in those alternatives, otherwise the whole thing just won't work.
Okay. Good points. Good answer.
Yeah, I thought, so we're a gateway, aren't we, in terms of two numbers really, so 999 and 111 as well, which we provide, some more successfully than others, I have to say. But that's too late, isn't it? Because actually by the time someone's dialed 999 or 111, actually by the time that happens is that the response will be, if it's an ambulance, is that that patient generally, if there's no other services available, will get conveyed into the hospital. And if those patients are, say, over 65, they'll generally find something wrong with them when they get them into hospital. That means they'll go into an acute bed, and that's not a good place to be if you really don't need to be there. And all the evidence from consultant sort of geriatricians around frail elderly admissions to hospital is that that's not a good place to be, and the best place is to be in the community. So some of the work that we've done with Cumbria Cumbria Health On Call, for instance, as the out-of-hours providers around pathways of care as an alternative to the ED, have meant that a lot of those patients can be managed in the community much more effectively as long as the response is timely. And that goes back to the caveat that colleagues have put on it, that those services need to be there. But what we found is that most patients we know about, don't we? If a patient's an elderly or frail elderly patient, they will have a GP that knows about their conditions and so on and so forth. So if we can know about that as well, then we can manage those patients in a different way. So care planning, for instance, as Debbie mentioned earlier on, is a phenomenally successful way of managing patients in the community that really doesn't happen to the degree that it needs to happen in this part of the Northwest from our perspective. So if you look at areas like, I'll give you an example, somewhere like Fylde or Blackpool, where they have 13,000 care plans for that community, is that the impact on their hospital is much less, and therefore funds that are actually put into the acute can be used much more effectively in the community. So some of this is about, I would suggest, a sort of invest to save in some areas so that there can be more investment in other areas. But there's a lot of work to be done, without a doubt.
Thank you. Okay, some very important points made and some good answers. Lady at the back there.
My name's Jean Armstrong. If I can first make a point and then ask a question. The point I would like to make is that several times it's been mentioned that we have, in effect, over-provision of services because of population. Can I just remind everybody that this county is not typical. It is the second lowest populated county in the country. It has particular problems. It's got 73 people per square kilometre. You can't possibly make comparisons with large urban areas. Please remember that in your considerations. The other thing is, I've read the report through several times. It says a lot, but I didn't find many facts to back up a lot of the premises that you put forward. Particularly some of the estimates of what will happen and how many people this will affect. Nothing that I saw that backed that up. But it led me to wonder, I looked at the bottom on the various management groups. There are several of them, so then I looked further. I'm not clear about the hierarchy of all those groups, I have to say. And I do understand that some of this is imposed by the NHS nationally. But has anything been done about studying the management and how and where efficiencies can be made there to save money?
Okay. Thank you. Yeah, management efficiencies. Debbie, you've got the mic.
The first thing to say is that I think we all very much appreciate what you say about the challenges of delivering care in remote and rural areas to urban populations very far from other areas. We do all appreciate that, but you will also know that that doesn't necessarily wash with other areas who say, but we've got problems of our own, we've got massive this, we've got massive that. So these things are always difficult, but we do fully appreciate those challenges because that's what we're living and working with every day and what we try to do. It's of course very difficult to put in a consultation document all the detail, all the facts and figures when we're consulting on a number of different and very complex areas. So when you, if you have access to the internet, if you go on the website, you'll be able to see that there is much more detailed information behind. There's various briefing notes which give a little bit more information, and then for those people who would really like to get into the detail, there is the full pre-consultation business case and all the supporting appendices with a wealth of facts and figures in there. So please, if you're interested, do have a look at that. Management costs. One of the things that we need to remember, I think, is that there is the health service is very complex. There are a lot of demands on us from our regulators. We have to ensure that we fulfill the requirements in relation to those regulatory mechanisms, and that is quite onerous. If we get some of our colleagues, clinical colleagues, a number of whom are sitting in the front row here, to do that instead of seeing patients, actually that's not good use of their time and puts even more pressure on. So there is undoubtedly a case to have managers who can actually do some of that stuff and allow the clinicians to get on with actually managing patient care. But you're absolutely right, we need to make those mechanisms as lean as possible and make them as effective as possible. Peter was saying before about us all having been in a meeting earlier. Apart from you escaped it, well done. And part of that was about discussing with partners across the health and care system. So it was full of senior managers from, when I say full, there was probably 12 of us there, but it was senior managers from across the county council, the commissioning group, the two trusts, and with general practice to look at how we can actually join things up better across our systems. And that is all about making things work more smoothly and be able to release some of those costs. And if you are interested to go into the pre-consultation business case, you'll see that we've made some estimates of some of the costs that we can take out there management-wise.
Just a few specifics on the last thing that Debbie touched on. So in terms of things like, could we have a single approach to how we do human resources? And it was great to hear the feedback from in terms of how the Partnership Trust HR team had worked around Brampton Community Hospital, but we may well be able to deliver a human resources service more effectively across the NHS. We may well be able to deliver some professional services that we do rely on, like managing the physical estate of all of our buildings, like how we utilise legal costs, because we do incur legal costs, like how we do procurement. So as an example, lots of people who work in the NHS are able to order the physical equipment that's needed to deliver care. Well, we know that if we did that in a smarter way, probably through one team, we could save a lot of money on buying our equipment. So those are the kind of other areas that we're also looking at. And as Debbie said, in the information on the website, it lists those out and it comes up with a financial figure that we think we can save.
Okay. Thank you. Very quickly, please, regard them.
It will be quickly. If I can just add to what I said about the area, the geography of the area, and your assertion that ambulances can come from Whitehaven in 48 minutes. I am actually a West Cumbrian, although I've lived here for many, many years, and I still have family in West Cumbria. I travelled from Workington yesterday, from the roundabout where ambulances would come off the road from Whitehaven to come to Carlisle. To get to the bottom of Wigton Road to the infirmary took us 50 minutes yesterday on a clear road yesterday evening. You can add 15 to 20 minutes to get from the hospital to that roundabout. I don't know where anybody's got that figure of 45 minutes from. I've travelled that road for 50 years and it cannot be done.
Okay.
Yeah, thank you. I think the figures are being looked at all the time, and actually, as an ambulance service, what we do have is years of historical data, and one thing we're very rich on is data. So an analysis of the travel times within the different emergency acuities has been done, and that's where that comes from. So, for instance, you will have a different journey time with somebody who is really critical on a red 1 transfer than you will with somebody with a green transfer, for instance. So the time comes from the analysis of the red transfers because of the acuity of the patients that are likely to be transferred being only those really sick patients.
So I can just to red, I assume, is a really serious case, and green. Yeah. Yeah.
So a red 1 or red 2 is the highest priority. Yeah, absolutely.
Thank you. Thanks, Mark. Okay. Other questions, please. Gentleman here.
Thank you. I'm reassured that you are talking to the County Council But would it not have been better if this had been a joint report on behalf of the County Council and the ambulance service and everybody else who's got to feed into this or be affected? Because it does seem to me that it's a little bit passing the buck from we need this, so the County Council have got to pick that gap up. There are going to be more patients transported by ambulance. Possibly, I would suspect, more people are going to need the air ambulance. Is the money there to provide these services? Or are we going to be losing out that way? The other suspicion I have is that we could learn quite a bit from talking to colleagues in other remote areas. We're next door to one in Northumberland. We've got people down in Cornwall who've got the same sort of problems. I think we need to look at what everybody's doing and learn from best practice. And I hope it isn't too late now to do this, because I think we are in a critical situation, and if we make mistakes now, we're going to suffer from this for a very long time.
Yeah, thank you. Points well made. So the first point is about should this be approached as a joint exercise?
Yes, and in terms of the partnership, the council are partners with us. So the council have had a place on our system leadership board as we've been going through the process of talking about our strategy. When we've got into putting on the table the small set of things about which we want to undertake formal consultation, I think and I don't want to talk for the council, but I think their perspective is that they reserve the right from a political perspective to express a view and opinion in the consultation process. But that hasn't stopped them from being partners to the overarching aspiration around the development of integrated care communities, care closer to home, and making sure that we develop high quality, safe services. So they are definitely partners in that. I think but reserve that right in terms of expressing an opinion about the things that are proposed in the consultation process, which is why they're not on the platform with us presenting those. That's the health system that are presenting this set of issues. In terms of shunting or transferring risk to the county council, that's absolutely not what we're trying to do. I think what we've been trying to do as a set of leaders is to jointly own all of the problems and jointly try and come up with some solutions to those. So I am as concerned about social care as I am about community services, and similarly our partners in social care feel the same. So I think that what we're trying to do is to think about how we use our collective resources in a much better way, and that might mean actually that money that has traditionally gone into some NHS services might be better spent on social care actually, and strengthening those supporting services that keep people healthy and well and stop them getting to a point where they need more intensive forms of care. And that is certainly the conversation that we have been having. And then Debbie was talking about how we've been thinking about how we organise ourselves, I suppose, so that we can make some of those decisions, so that we don't look at the resources that we've got through an organisational lens, saying, well, it's okay as long as my organisation is all right, actually. We're trying to look at it from the perspective of a person who lives in Cumbria and the money that we have available in Cumbria to do the best possible things, regardless of where that money currently sits in the system.
Perhaps I could ask Mark to address the question about learning from other remote communities.
Yeah, absolutely. So, I mean, we've consulted with the Association of Ambulance Chief Executives, who have provided comment on the consultation, and that will be returned next week when Martin Flaherty comes back. But also in terms of, Debbie mentioned earlier on, is that the maternity situation in the West is it doesn't matter whether you look at any of those options, they all carry risk, and therefore the approach to that has to be, how do you best mitigate that risk? So we've looked around the country, and my colleagues have been down to Wales and to look at the Pembrokeshire model, which is similar. There's subtle differences, but similar. How does that work? How can we feed back from that? And all of that information, both soft and hard information, will be fed into, to the way that we look at developing things like standard operating procedures that will best mitigate the risk to patients, and so that information has been sought. The other thing is we have a lot of experience of reconfiguration, and not just in Cumbria. So we've had similar reconfigurations down into the south of the patch, and actually we've done work abroad with places like South Australia, where they have geographical challenges, where 95% of their population live in Adelaide and the rest is very geographical. So we can bring all that knowledge to our approach to the responses and the challenges of the potential options within the documents.
Okay. Anyone else?
Yeah, just to reinforce what you've said, we've looked at a number of different experiences as well as North Wales and some of the others. So we have looked at Cornwall. We've also been in discussion with colleagues in the Highlands. We've looked at things in Northumberland and how they work. We've looked at what happens in New Zealand, what happens in Norway, and not just about remote and rural areas either. Obviously, there's examples of best practice which have not necessarily have rural aspects to them, where people are testing out new models of care. So that includes North West London, who have done something very similar to integrated care communities, as well as Devon, who are quite famous for their work in their integrated care community equivalent. So we have been drawing on a lot of external research where we publish papers, but also asking experts to come in and advise us. You asked about ambulances and money for ambulances, and there is money built in when we've done the analysis of what the different scenarios would mean, where there are transport issues, that's all been built in as well. You also asked a specific question about air ambulances, and it's probably worth picking that up because that was talked about in some of the early pre-consultation engagement sessions, and I'm trying to remember what we called it then. Was it helimedicine or something? But we were looking at how we could improve some of the air ambulance services so that when they were needed, they would be there. And we've called on a gentleman called Stephen Hearns, who is the lead clinician in Glasgow for the air ambulance service that covers all of Scotland. And he's talked to us about what an emergency retrieval system would look like and worked with us about how we should go about improving the current arrangements that we've got in partnership with colleagues from the Great North Air Ambulance and from North West Air Ambulance Service and NWAS colleagues. So we're doing lots of active work on that.
Thank you. There's a gentleman at the back there.
The name is David Kershaw, and I'm really asking a question relating to diabetes. I know it takes a large amount of the money. My brother's diabetic and he lives in Yorkshire, and so I've learnt a lot about being a diabetic and the good service that he receives. About every 3 years for the last 10 years, I've had need to visit a chiropodist or a podiatrist at the Cottage Hospital in Brampton. I don't know whether this is something you want to comment on. It's a sort of positive comment. And every time you fill in a form and you send it to a clinic somewhere in Carlisle and a form comes back, but it usually takes 3 months. Now, I sent off this November. Things were happening to my feet that I thought, yes, I better have another. And of course, I never complained at the length of time it took, because I realised many of the NHS chiropodists were very, very busy dealing with diabetics, so it didn't surprise me. And yet on this occasion, I've got an appointment within 2 weeks, and I'm just interested. I mean, is it a simple answer that you've now got more staff in chiropody departments? is it that people are fed up of waiting so long, so they tend to go privately? And I'm just interested that, you know, suddenly it's down to a 2-month wait. Am I just lucky on this occasion?
It's a very specific question, and thank you for that. I suspect it might be one that we have to come back to you, but I'll ask the panel to respond.
So, David, thank you for your question, and I'm glad you didn't have to wait as long this time. Unfortunately, I don't think we're going to be able to answer your specific question about the number of podiatrists. But if you'll forgive me, I'd like to say something about diabetes, though, particularly type 2 diabetes. So firstly, we know that in our part of the world, more people do have type 2 diabetes than the average would be in England. From that, we know that if people are not supported to look after themselves and to manage their diabetes, then they are more likely to have other complications and other problems. So it really helps if we can work with people who have type 2 diabetes to manage their blood pressure, to manage their cholesterol, to measure around their what's called their HbA1c. And in terms of feet, obviously one of the issues that can happen to people with type 2 diabetes is around small veins, which can present in your feet. And in the worst case, of course, some people do ultimately have amputations. Now, if we can find a better way of helping people with type 2 diabetes to understand the condition, to look after themselves, to support themselves and each other, then we can improve the outcomes for those people and avoid those horrible things that can happen. And that will also help us to reduce our costs. And one really good way we can do that is by providing what we call structured patient education. So now we offer that everybody who is diagnosed with type 2 diabetes can go on a course called Desmond that teaches them all about type 2 diabetes and how they can look after themselves. And those kinds of different approaches to helping people to understand their condition and live more successfully with it are a key part of what we want to do. Of course, we'd rather avoid type 2 diabetes in the first place. So something else that we've made an investment in, and we're getting support from broader money outside of Cumbria, is to help people at risk of diabetes have different approaches to their exercise and their nutrition and avoid having the condition in the first place. So apologies we can't answer your exact question on podiatry. I'm sure we've made a note of it. But type 2 diabetes is a really good example, as is type 1 actually, of how we can work differently to support people to look after themselves.
Thank you. We've got a lady up there.
Hi, we're aware that the integrated care communities, they are actually up and running in Carlisle at the moment. My question basically is, while all this consultation's going ahead, is there any monitoring taking place in the A&A departments, for example, with regards to admissions from that particular area? Also, how many readmissions are happening within the hospital in the aim of trying to get people out quicker?
Okay, thank you.
Yeah, we... So I can't answer what the answer is, as in whether it's going up or down, specific to Carlisle. What I can say, within the integrated care communities, what we've agreed is a set of outcomes that we want those integrated care communities to deliver. And one of them is about supporting people to receive their care when they are in crisis before they end up in A&E. So it's Mark's point about putting in the right level of fast response that enables them, somebody to be supported before they end up in A&E. So that's the idea. I mean, Colin might have a better idea as a local GP working out of Carlisle about whether they're going up or down in terms of numbers to Dr. Patterson sitting on the front row at the moment. Or he might not want to. He's not looking very keen on answering that question, actually. But we've got a number of integrated care communities that are up and running. So we've got 3 early adopters. Carlisle is one of those that's just coming online, and then the idea that all of our integrated care communities we will develop over the next sort of 3 to 6 months.
So you've Dr. Patterson.
And we will be monitoring what impact they have.
Okay.
Thank you, Claire. My name is Colin Patterson. I'm a GP in Carlisle, and one of the partners in an organisation called Carlisle Healthcare, which is a merger of 3 practices, probably 4 by next year, looking after At the moment, 38,000 patients. In the future, 45,000 patients. I think it's too early to say anything concrete. But one of the things that we have set up by having a larger group of people working in the same organisation, with the same management, with the same patient record, with one point of contact, is what we call an MDT, multidisciplinary team. Every morning, we now have enough staff to permit that a GP and other staff members will review what's happened with CHOC overnight, with people with care plans, who's causing concern, the hot cases, who is on the horizon who might be causing some concern, who's people who are on the palliative care list, who are end-of-life care, and those who could benefit from coming onto care plans. So what we've got is not perfection. What we've got is the beginning of a journey to start getting to file coast. So how do you get 13,000 care records? You've got to start somewhere. You've got to start with 0 care records. Now, we're not starting there. We have everybody in the care home in Carlisle has a care record. Everybody in the end-of-life palliative care has a care record. So what we're hoping to do through this larger group of merged practices is to have the ability to have work streams that we otherwise couldn't have in the smaller practices. Now, we don't have to be merged, which we made a decision when we thought of a series of questions about how do we organize ourselves, how do we know the patient is a single record, how do we know there's one centre that's going to coordinate things, and that was the answer for us. But here, in rural Carlisle district, you have one large practice, Brampton, and you have one smaller practice, Longtown. And the question is, not only how can Longtown and Brampton work together, but also how can Carlisle and Longtown start thinking of providing services to those Carlisle registered patients who actually live in what you would think is your patch. And I think that would be an interesting thing to see how the rural ICC, Brampton and Longtown, could cooperate with the urban ICCs in providing those community-based services to patients who continue to have their registration with urban practices. The other thing the rural ICC is doing, Mark Olban, one of your GPs, is very keen on children's services, and we're trying to see if we could have a consultant paediatrician work with the partners at Brampton and Longtown to see children at the practice and provide advice. And this is really bringing the integration of our consultant colleagues and their nursing colleagues with the GPs. And we're following a model, not in a rural area, it's a model from London about how you integrate those services. And we're looking very forward to that working so that we can take the lessons here in the rural area and apply them in the urban area. I could blather on a lot longer, but those are 2 examples of how we are going to develop things. I love talking about Pathfinder as well, where we try and stop people being admitted by allowing the paramedics speak directly to GPs. But there are many examples, and I think really the last point I'm going to make, they're trying to set me down here, is that I'm not really interested in this bit. I know it's very important, and I'm often told we have to do this. I'm interested how many people we have in the room like this when we want to talk about ICCs. Well, are we going to have the same number of people here when we're talking about ICCs? You know, I'll give you a good bet that we won't. But I actually think that's where the real test is going to be. The community engagement that we get about ICCs. And that's not just about you turning up. That's about how we together talk about what is in our communal best interest and how we share things, share decision making, so that actually there's nobody going, I wonder what if. They go, I know who to ask, and I know the meeting to go to make a difference.
Colin, I know you want to sit down, but did you just want to say something about the out of hospital, the virtual hospital team that has been set up, just in terms of, because that's been having some real positive impacts, hasn't it? So it's worth just referencing it.
Right, Claire wants me to bigger up her trust. Look, we took a really difficult journey in Carlisle about a unit called Reaver House. Some of you may have read about this in the newspapers. where we had a few beds, an ever-shrinking number of beds it seemed to be, and we just weren't supporting enough people who had needs, and we decided on a model of hospital at home where we took the same resources we were expending, but yet we support, I think, twice, maybe on some weeks, depending on the case mix, 3 times the number of people in their community setting with the hospital at home team. Now, this is very, very difficult because I know, and there's some examples given for some people today, that we concentrate on the really difficult cases. And yes, I hear the pain and anguish about that poor lady who was falling over in the ambulance on the way back home, and you're just going, my goodness, I hope she doesn't break her hip. We'll really be stuck there. And there is no doubt about it. We've got to think really hard about the really difficult cases. But what we want to do is get that overwhelming number of people who have problems that can be solved with a relatively modest amount of input to stop things getting further. Now, I know folks may say, but the folks of a certain age and complexity are getting ever greater. But if we just allow the leak, as it were, of people who aren't really prevented from having illnesses to continue to cascade down, then we're never going to have the space to help the poor people who require more intensive treatment. And again, we need more work with our colleagues in social services about the type of way of thinking about how people journey from being independent people to being in a care home, and the fact it just doesn't flip one day, that there's a whole lot of steps in the way. And we have a care home team in Carlisle, and one of my hopes for that is it moves on from being the care home team and it moves into the before the care home team, and it starts to actually move out to people and say, what can we do so you don't come to be part of our care home team? What can we do into your home so that you don't have to be admitted to a residential home? I could go on at length, but I think those are the sorts of conversations that we could have.
Thank you. Thanks very much.
Can I pick up? I just wanted to pick up on something that Colin mentioned there, but didn't expand upon, which is the use of something called Pathfinder. And this is it's a tool that allows paramedics to determine where a patient's care should be delivered. In other words, it's under the banner right skill, right time, right place, so that the decisions we make at the front end don't disproportionately impact on the rest of the hospital. And what that allows us to do is keep people that don't need inpatient intervention closer to home, so that if you're sick, when you really do need to be in hospital, that the resources are there to treat you in a timely and efficient way. And this is really about us taking responsibility to work closely with colleagues in primary care to make sure that decisions about patients' pathways are made on a clinician-to-clinician basis, on a shared risk basis, so that patients' care is delivered in the best possible way. And this sort of initiative has been rolled out over, I think, 7 of the 10 English ambulance services because of the positive impact it's had on the quality of care actually delivered in hospital, because it frees up bed days for patients who actually need to be there. And that's something we'd like to work very closely on relating to the ICCs, to make sure that paramedics are not just seen as a transport option, but are seen as an option that can provide an enhanced assessment of a patient and then be referred into a primary care provider.
Thank you. Thanks very much. Any more questions, please? So we've got 2. So I'll go to John and I'll come to you. There.
I'd just like to ask the question, you're doing things in different ways, you're changing who does what and where they do it. Fantastic. For example, the ancillary services that we've suggested could go into Brampton Hospital rather than being done at the acute hospital, and the involvement of the local medical practice in that. I'm just wondering whether that's going to be a bit stymied by turf wars as to which income stream is it. Does the income stream go to the GP practice? Does it go to the partnership trust? Does it go to the acute trust? You know, everybody's going to protect their patch to some degree. What is your strategy for avoiding those turf wars?
You know, we're getting late in the evening, but it's a really good question. So thank you for asking it. And without going into the intricacies of how NHS finances flow, though very happy to do that afterwards if it's helpful. In one way, us having a massive financial challenge across all of the NHS organisations. In one way, that's helpful, because none of the individual organisations can get out of this on their own. We can no longer be in any kind of position whereby we move costs to the hospital, or we move costs to the general practice, or we move costs to the social care system in the way that we were asked about earlier. That's not going to work. What we have to do is find the right way so the money can go where it's needed, where it can secure the right staff that can deliver the best possible benefit to the service user, and that none of that nonsense about how money flows in the NHS gets in the way. Now, that's easier said than done, and if you've got some caution about that, you're right to have some caution about that. But all of our financial plans are what we termed organisational neutral. So they're all about spending the money where it's needed, and we will make the money work in the best way that we have to. But the organisational stuff cannot get in the way of us spending the finite resources that we've got to best effect.
Thank you. Lady there.
I just really wanted to make a comment. You've talked a very fine talk. I just hope you can walk the very fine walk.
Thank you. A very powerful challenge.
And I'm probably not going to be able to respond to it in exactly the way that you wanted, but I wanted to pick up on something a lady at the back said, which I think relates to this. And you asked about readmissions. We need to be making sure that in everything that we are doing that is about change and hopefully improvement, that we are measuring what we're doing, that we're identifying what our criteria for success are before we start them, that we are saying, yes, this is how we'll know when we'll be successful, and we're also measuring things which may impact on the other side, which may be bad things like, well, we're reducing our lengths of stay, that's jolly good, but a whole load of patients are turning back up to be readmitted, that would be a bad thing. So I think it's really important that we spend considerable time and thinking very carefully in conjunction with our clinical staff, but also with our communities and public, about what our measures are that will help us understand how we're doing and when we have actually walked the walk or not.
No, I think it's it's Colin's challenge, isn't it? Of as we develop integrated care communities, that as much as anything is a partnership between statutory health and care organisations and the public. And we want to be held to account, actually, and we want you to play a role in, as Colin says, not just in you know, giving your views about what we're consulting on, but also as we move into implementation and that broader strategy of integrated care communities, really playing a very strong role and challenging us in the way that we implement it. As Colin says, it'd be fantastic if as we start to develop those, we got, you know, you engaged and, you know, expressing your views and opinions as partners within that, because that's the way that you will make sure that we walk the walk.
Thank you. Thanks very much. So we have a question. Well, question over there.
We were just talking about care plans. If someone has a care plan and they have a DNA CPR form, and the date of the DNA CPR form is the 20th of November.
Sorry, I don't know what a DNA CPR...
Do not resuscitate.
Okay, thank you.
Okay. And the date on that form is the 20th of November 2015. And you come along to their house today, which is the 21st. Can you tell me what's going to happen, please?
Yeah, I can tell you what I think should happen, and that's that somebody takes a common sense approach to that position, because clearly there will be a very black and white approach taken by some people. We've set up services within the Northwest around clinical support hubs, which provides clinician-to-clinician advice for for crews on scene, and we encourage those crews to come back onto scene before they make a decision. Clearly, that's a time-critical position, but they're encouraged to take the views of the well, look at the existing care plan and make a pragmatic view on that. So, I can't determine exactly what would happen on every single instant, but clearly what we don't want is to take people who want the dignity of dying at home into hospital inappropriately.
From a patient perspective, from a human being perspective, and from a service provider perspective, this is one area which is so inefficient.
Yes.
You don't, if you make your decision not to be resuscitated, you have made your decision, and it's like donating your organs. You know, you've made the decision to do it.
Yeah. I completely agree with you, and actually I think it's this Thursday there's a summit in our headquarters to look at EPACs, which is the sort of palliative care end-of-life planning situation, because we are clearly in a position where we need to improve our interoperability and our electronic, our IT capability to make sure that we can see up-to-date position around care plans and everything, but I'm completely with you on that. What I can't do is say 100% what would happen in every incident.
Yeah, thank you. So I think that's a point well made, and we've clearly noted. Right, any more questions? Sorry, Nick. So if you could just stand up and introduce yourself.
I'm Nick Strong. I'm the Associate Medical Director for Surgical Services. There was a question over here somewhere about locums, which one way or another didn't get answered. I wouldn't like to go away with not getting an answer. There are two kinds of locums in the NHS. There are NHS locums that are paid essentially the same rate as everybody else. When people come from outside the European Union, they may have to work in a label locum for some years in order to acquire the documents that need to allow them to become a substantive consultant. That's why you could end up seeing the same locum over quite a long period. That isn't the group that we're bothered about when we go on about locums. They're really just pre-substantive. The problem are agency locums, and agency locums can end up costing, an individual locum can end up costing 4 times as much as an ordinary consultant, so several hundreds of thousands of pounds a year, and that's what we're doing our utmost to get back from and get on to a proper substantive workforce.
Thank you for that clarification, Nick. Any further questions? There's a question at the back there.
I'd just like to ask how patient participation is going to continue in the future. And is that going to be effective? Because it hasn't been in the past.
Okay.
Was that patient participation you asked there?
Yes.
Yeah, how it's going to continue?
Sorry. Yes.
Yeah, and I think that although there have been a lot of different ways of doing that, I don't think that we claim that we've got it sorted. I think we've had some good examples, I suppose. So some of the work that we're doing with the Maryport community, for example, at the moment, on the back of this, so it's almost as if we do our best patient participation when we've got a burning platform. So when we've peed off the community, excuse my language, to an extent that that they're angry, and then that's when we do the best public participation, actually. What I would really like is to use the integrated care communities to develop that model without having got there first. So without, so using, working with the communities in a much more constructive way around the totality of what we want our place-based visions to look like for those areas, and then starting to have really good conversations about the use of resources in those areas so that local people are working with us on what are the best solutions. So that's the kind of aspiration. I don't think that we've had it sorted. I think we've got some good examples, the work that we've done in Millham, the work that we've done in Maryport, but we need to replicate that and scale up.
But it needs to continue. People need to have access when things are going wrong, and how are they going to have that access, particularly the most vulnerable people who are probably not sitting here tonight. And those are I'm most concerned about, is them people, the people that do fall off the back of an ambulance. How do you rectify that? And quickly, if you haven't got the provision in the first place, how are you going to improve that?
Okay, so I think the question is really about...
it's accessing. How do you improve things quickly?
Okay, thank you. Yeah, and it's a very well-made point. So how do you've talked about burning platforms. We're also talking about vulnerable groups. How do we include the vulnerable groups within patient participation?
I'm not sure whether you're meaning specifically when things go wrong or just making sure that we reach out to those disadvantaged groups. Overall. Yeah. Yeah.
Okay, thank you.
And I think that's really important. So what Claire's been talking about is how we can use some of the things that we've been talking about in terms of integrated care communities to help mobilise and ensure that our communities and our patients and our public are engaged, and that's one mechanism. Practices have all got patient participation groups, and those will undoubtedly help create some of that.
Can we just allow the panel to answer first? Thank you.
I think we need different things in different areas. So we should be encouraging practices to have patient participation groups, but those, again, will attract a certain type of patient. We also need to make sure that we have communities who are able to input into their integrated care communities. We also need to make sure that we've got mechanisms that reach out to those most disadvantaged and having less of a voice, and there's lots of mechanisms to do that. My personal view is that we need to use community development principles which do focus on reducing inequalities, which are about ensuring that communities or individual patient groups, individual client groups can set the agenda for what's important to them, rather than it just being about our agenda. And tonight, this has been about our agenda. It's been about consultation, and is about developing that continuous dialogue. So there's not one answer. It's not going to be, well, practice patient participation groups are the answer to everything, or engagement mechanisms through integrated care communities are the answer to everything. We need to have a range of different mechanisms operating throughout our organisations, working in partnership, and learn from what happens in other areas of best practice. And we only have to look, I think, to our partners in local authorities to see where some mechanisms do actually work very well, and we need to learn from that in health.
Thank you. So, clear message to be taken as part of the consultation. So we've got 5 minutes of injury time because we kicked off a little bit late. We're due to finish at 8:30, so I'm going to allow any last questions. One question from the gentleman there.
ICCs sound a very good idea, but they will be very expensive, requiring a lot of workforce. Have you got a budget for, say, an ICC in the Brampton and Longtown area? And when might this scheme come into place? And secondly, with particular reference to the community hospitals that may lose their beds, I would suggest that this must not happen at all, but must not happen until the ICCs in those areas have proved to be effective. That may take 5 or 6 years or even longer for the ICCs to work before it can be seen whether they really do work. I hope they do, but it's got to be seen.
Yes.
Thank you.
So yes, we have a budget. As Peter said, when we pulled together the pre-consultation business case, we identified how much money we'd need to fund the transition. So how much would we need to invest in some of those community alternatives in order to be able to disinvest in some of the areas of care that we know are not effective. So there is a budget. It hasn't yet been split to an integrated care community level. So we haven't yet, because it wouldn't be appropriate while we're in the middle of a consultation process to have done that. So once we've kind of got through the consultation and we're starting to get our integrated care communities up and running, we will need to make some decisions about how that money is invested. But the principle would be that each of those 8 integrated care community areas would be allocated some money. Now, it comes back to the lady's point about patient participation to some extent, because in an ideal world, what I'd really love is for us to have a partnership with the public and the local stakeholders about how that money is used. You know, you will have some ideas about what's relevant to your local community that we may not understand fully. So it should really be a partnership about deciding where the money's invested. And the other bit about the transition, you're absolutely right that we've already said that to some extent we want to see the impact that the integrated care communities have before we start to make changes. I don't think we've got 5 years though. I've got to be honest. Given the financial position that we've got and given our need to demonstrate this, I don't think we've got 5 years to wait to see whether integrated care communities work. I think and in the pre-consultation business case, we had started to model in what impact we thought they could have over the next 5 years, and there is some impact modelled in for next year. So we really need to do everything we can to make sure that those integrated care communities are successful. We are relying on them.
Okay. Thank you very much. Well, thank you very much. I'd like to thank the panel for their honest answers and taking it all today. Appreciate it. But most of all, I'd like to say thank you very much to everyone, each and every one of you that turned out tonight. I know it's not the best night, and I really appreciate the time that you've given. So I think, you know, thank you very much. I'd also like to thank the team that have put the consultations together, and also our colleagues from Soundsmiths who've done an excellent job on keeping me audible. So thank you very much. And that's it. Call the meeting to a close. Thank you.